Good morning, everyone. We have a full house here. I work here for the past 14 months and I haven't been to the niche, so it's nice coming here and seeing at last what Epilepsy WA do. Sorry. So I'm going to talk about stereo electroencephalography, or in short, it's called SEEG. I think this talk complements nicely the talk last year by Dr. Hari. And if people haven't seen that, they should probably go on the Epilepsy WA website and look at that. You know, he provides a broad surgical overview of the latest updates in neurosurgical epilepsy. So just a bit about myself. I won't be going too long on this. So I moved to Australia in 2008. I graduated in New South Wales in 2010. I did most of my core early training in Hunter Network in Newcastle, and then did my WA training between 2016 to 2018, and then finally moved to Melbourne to do my epilepsy subspecialty follow-up. And I've been working in the adult epilepsy service at Charles Gardner for the last 14 months. So I'll just talk very briefly about epilepsy. I'm sure if people have attended these talks, epilepsy is a very common condition, very common, the most common serious neurological disability. We estimate there are around 200,000 to 250,000 people with epilepsy in Australia. And if you translate that to Western Australian number, we're looking at 20 to 25,000 people. Most of these people will be well controlled in the community through their GPs and specialists, but there are approximately 30% of patients who are very difficult to treat. And these are the people we try and see and prioritize. So that translates to roughly for WA 6,000 to 8,000 patients who are drug resistant, meaning no matter how many drugs you try, they don't get seizure free or don't have substantial seizure reduction. So the more formal clinical definition, or what we use to guide us, is that drug-resistant epilepsy can be classified when people fail 2 medications. Now these medications should have failed not due to side effects or because they were the wrong drug for the patient's epilepsy, but because they did not work at the therapeutic doses. So once you fail 2 medications, the literature does not look very optimistic, and we do get variation in people who end up being seizure-free or having substantial seizure reduction, but we're looking at 5 to 10% of people with further drug changes ending up seizure-free. So generally speaking, people with drug-resistant epilepsy, the best option of successful treatment for them is usually surgical resection. So you find the epileptogenic source and you aim to basically resect it. So this is just a flow chart which will go through, what options available once patients are drug resistant. So one of the more popular one, which happens because mainly resource limitations, as well as some patients are just not surgical candidates due to other reasons, which I'll go into. So you keep on trying new drugs. There's a lot of research and trials, and every 10, 15 years we see a bunch of new drugs coming out. And these sometimes have unique mechanisms which in some patients do end up making them seizure free. So we remain optimistic, currently there's a drug, cenobamate, being provided by the hospital, which is giving very good early preliminary data. So people who are not surgical resective candidates but are drug resistant, they still can have different combinations, trying drugs, even older ones which were not tried before, and they can end up being seizure free. If patients are not surgical candidates, for example, if they have multiple sites in the brain which independently provoke seizures, or if there's an extensive lesion, or if the lesion overlaps very important brain areas, they can't have surgical resective surgery. But they can have other therapies which are not drugs based, so neuromodulation, and again, if you go to Hari's talk, he goes into more detail. I probably won't have time to go through all of this, but the common ones are vagal nerve stimulators, which is a device placed in your chest and which stimulates the vagus nerve every 5 minutes, and we can alter the parameters. And basically, the data is not very optimistic on seizure freedom, but we do find some people having substantial seizure reductions, some up to 50 to 70%. And those people whose burden of seizures don't reduce, we do find their seizure severity reduces. So this electrical stimulation protocol somehow modulates the epilepsy circuits deep in the brain, even when it's not targeting the actual epileptogenic source. We have a lot of dietary therapies. These are very hard to sustain. Most adults cannot adhere. They are based on usually a very high fat, low carbohydrate, and people have to be very strict on this. Ketogenic diet is one, but there's a lot of modifications to the diets which are out in the research area. We've got Atkins, modified Atkins, we've got oils which are being supplemented to modified dietary therapies. And then we have palliative surgical options, and these can be quite radical, like if a patient has very extensive brain lesion on one side, you can actually even do a full hemispherectomy because their seizures are so intractable, they're falling down, and they're having multiple seizures a day. So some people can have quite extensive palliative surgical resective therapies. Sometimes the connection between the two parts of the brain is resected, and that prevents tonic-clonic and drop seizures because those require both brains to be activated by the epileptic seizure. So the corpus callosotomy is another palliative surgical option to reduce the severity of the tonic-clonic and drop seizures. Now, this is the area which kind of I'm interested in, and we are trying to focus and increase the number of patients who we aim for resective, curative, or at least intending to cure the patient's epilepsy or substantially influence it with appropriate surgery. Now, for that, we do a lot of investigations, most of them non-invasive. And if the data is all lining up, for example, the patient has a lesion on one side of the brain and the seizure also looks like it's coming from the same side, then sometimes these patients need straightforward resection. They don't need any intermediary step. All the investigations seem to be lining up to one particular brain area. If the patient's epilepsy is more confusing, so, they might be having seizure types which don't align with what we see on the MRI, or if the MRI is completely normal, or if the imaging studies seem to be conflicting and divergent, and or the EEG and the imaging studies are conflicting, they need more specialized studies, and intracranial EEG is what we do. So the two common intracranial EEG options are subdural EEGs. Now, I don't have pictures. I was warned that last time when pictures were shown, some people ended up having a seizure. So, but that's what I was told. So this is basically a big craniotomy, and you put a big electrical grid on the surface of the brain to try and work out which part or which surface of the brain the maximal epileptogenic zone is. And this can be quite morbid. People can have quite a bit of complications. Sometimes we do need to do it, and we did do I think 1 or 2 last year, mainly because they can be close to areas which are very eloquent, and subdurals do have their advantages as well. They can localize on a surface level much better because you have a concentrated dense electrical grid spaced only a few millimeters. You can have up to 64, 128 electrodes on the surface. But we are moving more to stereo EEG. The world's moving to stereo EEG, and this is what we'll end up talking about in more detail. And if these patients have successful localization of their epileptogenicity or their epileptogenic focus, then they end up having resective surgery and everyone's happy. So what is stereo EEG? Stereo EEG is basically electrodes, which are thin wires, which are implanted in the brain very strategically to kind of try and work out where the epilepsy is coming from, okay? And these are planned very carefully based on all the data which we collect during the review of the patient, and that review in the clinics with the investigation can take a year or more. So with all that data, we end up devising a trajectory plan. Trajectory is just the direction in which these electrodes go in, and we try and understand the epilepsy using direct contact of these electrodes deep in the brain as well as the surface of the brain. With the subdurals, we couldn't go in deep. You can only work out what's happening on the surface, so the inner side of the brain and some deeper structures were being missed out. And the goal is to try and find out where the seizures are starting from. This can be different for every patient, so the trajectory plan is individualized and customized to that patient. And the reason it's used is, as I say, if the data is discordant, the MRI or the EEG or the scans are basically negative. We are not seeing the lesion because it's so subtle. If there's any issues with the non-invasive data, we end up doing this. It has very good safety. So this is the reason almost all major epilepsy centers have moved away from subdural grids to stereo EEG. The morbidity data is like 1%. The mortality data is like 0.2 or 0.1%. And patients tolerate this much better. Once they come out of theater, when they were having subdurals, they'll be in severe pain, a lot of discomfort. With this, they do complain of a headache on that night, but that is very quickly resolved and they're very much comfortable. And this, just a bit of history, it originated in the 60s actually. I mean, we in Australia have just started doing this in the last 10 to 12 years, mostly in the East, and here we started doing it last year. But it was there in Europe for the last 65 years, then spread from France to Italy, and Italy, the rest of Europe. US started doing a lot of these and transitioned from the subdurals in the last 10 to 20 years as well. And the outcome, usually most patients with stereo EEG end up having stereo guided surgery, and the numbers in the literature is 70%, and 70% of those will end up being seizure free. Now, what am I doing for time? Okay, I'll probably need to speed up. So patients suitable for surgery are those who are drug resistant. We don't just take people who are well controlled on treatment, who are not having any seizures. It is a resource intensive and low accessibility investigation, so we do select certain patients. They have to have focal seizures. We don't take generalized epileptic patients. And the seizure origin should be complex. It should be indeterminate. The non-invasive data should be not clear-cut. Or if you have brain lesions which just don't fit with the other investigations. So you might have a lesion on the left temporal lobe, but the epilepsy seems to originate from the right temporal lobe on the scalp EEG. And this evaluation stage is the longest part of the epilepsy, where they go through multiple investigations, which I'll go through. And during this time, we even decide whether a patient is a surgical candidate and if he's a stereo candidate. And then there's the trajectory planning, which is not too long. The actual SEEG phase, which is the implant, the actual monitoring explant, the post-SEEG phase, and then finally the resective surgery. So the evaluation phase is crucial. This is where patients are selected. It involves going through the epilepsy history in a lot of detail. When it started, what kind of seizures they're having, what kind of auras they're having, what kind of treatments they've tried, pharmacological, non-pharmacological, and we try and determine the clinical profile, the psychological profile of this patient, whether they'll be suitable, and once that's decided, we can proceed with further investigation. So almost all patients who have stereo EEG will come into hospital for a scalp video EEG. So this is the usual non-invasive EEG, which you can see on that head, where you have around 20 electrodes on the surface, and it gives us a crude localizing clues. It might tell us it's from the front of the brain, the epileptic seizure, or it's from the back, or it's from the left or the right. And during this time, sometimes we do reduce medication so that patients end up having seizures and we capture them. And what we look at is we look at the seizures in a lot of detail. There's this fancy word called semiology. Some of you might have heard of it, where we look at what's happening with the legs, the hand, what's happening with the eyes, are they moving to the right, to the left? We kind of try and organize a timeline of what's starting first. And that timeline and that progression can tell us how the seizure is spreading. So if a patient starts with a speech arrest, that might mean that his seizures are starting in the language area. Or if he starts with his hand contracting or spasming, that might mean it's in the motor area on the other side. And we also look at the electrical pattern on the scalp. Sometimes that can be contaminated a lot by artifacts, or because it's on the surface, there's a lot of distortion from the inside. And we might see broad patterns which are not very precise in localizing where it's actually coming from. But everyone gets that. This is probably the most important investigation before stereo. Most people will have a high resolution structural MRI where we're looking for a lesion. A lesional MRI epilepsy has considerably higher success rate, up to 2 to 3 times compared to non-lesional MRI. So if you have a lesion, a clear-cut lesion on MRI, there's a very good chance you might end up being seizure-free if that is resected. After that, we can do other studies, one of which is a PET. So this is a radioactive fluorine which is attached to glucose, a particular kind of glucose compound. And because the brain's very metabolically active, it takes up a lot of glucose. And those parts which might be epileptic might not be as bright as other parts, okay? So we compare a lot between right and left. In this picture over here, you can see the right side, although it's a bit subtle, at the front of the temporal lobe is a bit less shiny than the left side. The right side is the arrow side, okay? It's normally inverted on scans. So MRI, PET, and sometimes we do a specialized SPECT scan, which is an injection which we administer. It's also radioactive. It's administered during the time of a patient's seizure. So you'll get scientists sitting besides the patient being monitored in the epilepsy unit. And when they have the seizure, or if they give us a signal, the scientist will quickly inject this radioactive agent, and this will go and distribute in the brain in the pattern of how the blood flow is. So if one side has epileptic activity, that side will have more blood flow, and this agent will kind of concentrate more on that side. And then they end up having a scan. The half-life of this radioisotope is 4 to 6 hours, so we only have a 6-hour window during the daytime where we hope the patient will have a seizure and we can inject this. It's a very resource intensive. It needs 2 scientists. You need a full week, and you need the time window. Sometimes we bring in patients, they don't have seizures during their time window. They might have them at night. So not everyone ends up getting this. So these are all complementary tests, and then they might end up having they'll always end up having a neuropsychological testing, which is a neuropsychologist going through the cognitive profile. It's done in the clinic. They'll sit down. It's a pen and paper test where they'll go through a lot of questions, testing different aspects of memory, different aspects of language. They might give you a list of words and then test your recall, speech fluency, speed of processing, executive function. And this might, on some occasions, tell us, okay, there is some focal deficit in cognition. Maybe a patient's verbal memory is severely impacted. That might mean that the left temporal lobe is affected. And it also gives a profile which we can compare after surgery and resection, how the surgery has impacted the patient's cognitive and psychological profile. We don't have too much access to functional MRI. Sometimes we send them to the East, but they do it here on and off. It is, again, time intensive, but this is a specialized MRI which can be used to determine where patients' language centers are. So people in the MR scanner are given a task to do, and we look for certain signal changes in real time, and that can point towards certain speech areas. And there's a lot of other tests which I can't go through in, but they are available in patchy locations. You know, we can have a MEG, high density EEG, and other more advanced functional MRI plus EEG hybrids. And then all this data is collected. We sit down in meetings, we decide first amongst the neurologist, and then we, with the neurosurgeon, neuropsychologist, all sit down, and during these meetings we decide, okay, this patient is a good surgical candidate, but there's this, and this. We need to go down track of stereo EEG, and we discuss the main hypothesis, where we think the epilepsy is coming from, and other contending hypotheses. And then starts the main work. Once a patient selected, the surgeon and we sit down, the epileptologist, we devise trajectory plans based on what we think the main hypotheses are. So we might implant, for example, a patient on the right with temporal trajectories and some frontal and some insular, trying to make sure that we're not missing out areas which might be not showing up on the non-invasive tests, but which might actually be the culprit areas. So they end up getting these trajectories, and this is done, you know, over a day, sometimes a few days. Most centers around the world, the neurologists and epileptologists plan these trajectories. Here we sit down with the surgeon, and the surgeon has his preference of certain angles and areas on the skull which he doesn't like to go in, so the surgeon helps us with this trajectory planning. And then how we get the trajectories in, there's a range of options again available. The most advanced and sophisticated is a robot, which is at the left top corner. And Hari, in his previous presentation, if you go, you'll see a video of him talking about the robotic implants he did in Canada before coming in. The most common one is what is called the frame, the frame in black. It's called a CRW frame, and that's very time consuming, because every trajectory inside the theater, you have to dial up the numbers. So you'll have to adjust the coordinates, and you'll have to adjust nearly 5 numbers for the frame to provide the direction for the trajectory to go in. Here we use a certain pre-planned trajectory frame. It's called a star-fixed frame, and it's basically designed via 3D printing, customized for the patient. So we will send the trajectory plan to the USA in the state of Maine, and they will basically send this frame, which is already giving us the hubs of where to put the trajectories. And just before having the actual trajectories, people will come in quickly for fiducials. These are small anchors placed in the skull in theater. That will take a few hours. They'll go home the same day. They'll have a scan, and that's used in designing the frame, because the frame will actually attach to these anchors. So they'll get 4 to 6 anchors which are implanted inside the skull, and those anchors will stay until the procedure is completed. And so those images we obtained with the anchors and the trajectory plans, we send it to the US, and they basically send us the frame. And I've got a quick
may arise from There's no guesswork here. A team of doctors has worked round the clock to make sure they're inserted exactly where they should be. They use this mould that was designed specifically for Sam and made in the United States.
We would actually attach this to the patient's skull at the time of the operation and place our electrodes using these pre-planned trajectories into each of these hubs.
We are guilty of throwing this word around a lot, but this really is a game changer for patients like...
So that was our surgeon, Hari, and this was on Channel 7 last year after we did our first case. You know, there were at least three media videos on this, you know, and I think they're available on YouTube, so you can go through the story of the patient and all. So the actual implant day is pretty streamlined because we already have the custom molded frame. They come in on the day. It takes 2 to 3 hours, generally speaking, under anesthetic, where the electrodes are implanted. And that's the electrode we use. It's manufactured in France. And the very tip above the hub, I don't know if I can, you know, so this, where should I? So that very tip over there is the actual recording device. Okay, so that's the most important part of the whole electrode. So they have that done, they go to the recovery, they have a CT scan making sure there's no bleeds or anything, and then they come to the video high density unit, and then they end up in the video monitoring unit, and the recording starts actually on the same night. And then is all the hard work. We are basically looking at a lot of electrical data. The few patients we have had have ranged from 120 to 200 electrode contacts. So you're looking at least 200 lines of data. We arrange this in a certain manner where we can decide which areas of the brain each block represents. And this is actually the exciting bit for us, because we actually get to see intracranially how a patient's seizure looks. So although it takes a lot of time, we're looking through 10-second pages. The scientists are looking at it, the doctors are looking at it, and basically this is where we actually study the seizures. So again, similar to the video EEG, they will have the meds reduced, and we will kind of wait for seizures to happen, and then we study those in detail using the intracranial signature. And most of the time, these patients also end up having something called cortical stimulation. So although these electrodes are mostly recording devices, you can even send electrical currents through them and stimulate the brain. So you take 2 contacts. So if you can see, this one I think has 8 contacts at the top. So a pair of contacts, you'll pass a small current, and that will stimulate the brain region around it, and it can excite that brain region or it can inhibit. So if it's in the let's say the motor cortex or your movement cortex, you might see a flinch of the hand. Or if it's in your speech center, if you're speaking or reading something, you might pause, you might not be able to get your words out. So that allows us using the stimulation protocol to functionally map some of the regions of the brain which we like to map, which is language, the motor cortex, and the visual cortex. So, but the trajectories are not implanted based on functional mapping, they are implanted based on the patient's epilepsy network. So sometimes they do not overlap with these important areas, and this is one of the limitations of cortical stimulation in stereo EEG. And we are basically real-time monitoring. The patient's awake, he's interacting with us, we are sending currents and basically assessing for their responses. We also like to provoke seizures, so it's always good when we can actually, after the 1 or 2 weeks of data collection, we come up with a more clear-cut hypothesis, hopefully, compared to the pre-invasive data, and then we like to stimulate those areas and try and provoke a seizure. seizure, and that gives us extra confidence that yes, this area is more epileptogenic. The other areas we stimulated did not provoke a seizure, and basically that is another added layer of confidence that we are in the right area. So provoking seizures is always more good for the prognosis of the stereo EEG. And finally, not every patient has this, but again, this same electrode, it's a very smart electrode device. You can even burn tissue. So the stimulation parameters used in the previous section, which I talked about, are sub-threshold. They don't cause any damage to the brain tissue. This one, radiofrequency ablation, is where you really amp up the current and the voltage, and this basically cooks or ablates the brain tissue, and you end up with these small lesions. You know, here it's near kind of the posterior aspect of the temporal and the frontal lobe. And now this radiofrequency ablation sometimes can substantially reduce the patient's epilepsy if that's the area which is involved. We do not expect seizure freedom because these electrodes are not designed for ablation. And again, if you go to Hari's talk, he talks about actual ablation device which he's trying to get in WA, which is a laser interstitial ablation device, which does very thorough ablation compared to these ones, which are usually recording devices, but have the capacity to ablate as well. So the seizure freedom rates are very low. If we are in the right area and we've found the epileptogenic zone and the seizure reduces substantially, that again is another pointer that this patient's epilepsy will be able to be managed successfully via resection. And finally, you know, the explant, so the ablation as well can be done bedside. The explant is done in theater, and it's a simple procedure, an hour. A CT scan is done again to make sure during the 2 weeks there was no complication and no bleed. So that's kind of the SEEG summary. You know, it's a very a unique investigation. It's a very safe investigation. The outcomes in the literature look good. It has a lot of potential compared to the non-invasive investigations we have. But there are limitations. It's not a cure, it's a diagnostic tool. It's supposed to be another step towards eventual resective surgery. And some patients, unfortunately, even if we carefully select them, sometimes they end up not being surgical candidates because the epileptogenic zone, for example, overlaps with important brain functions, or the epileptogenic network is very broad and it's covering a lot of brain. Some patients might even have bilateral or multiple seizure foci. And our first patient was thought to be one-sided epilepsy, ended up having seizures coming out from both sides of the brain. So at this stage, she is not having surgery, but we're still working on the data and seeing if there are other options available. And the complexity of the epilepsy, so not all epilepsy is a small, discrete lesion where the seizure starts. Sometimes it's a network because the brain's highly interconnected. When these trajectories monitor the seizure, sometimes 3, 4, 5, 6 different parts of the brain are just firing off at the same time. And this epilepsy network term is being used for these very complex patients where the epilepsy is not clearly starting in one discrete area, but it's just starting in a broad area. And what we're seeing is the fast seizure discharge in many electrodes. And accuracy limitations, I mean, the surgeons are very good, the frames are very good. The robot's the best, but the frame we're using, looking at the 3 cases, it's been pretty good, to be honest. I mean, there's been 1 or 2 in each patient which are a bit out of the pre-plant trajectory by 1 millimeter or 2 millimeters. Sometimes that can have an impact if there's an important lesion, but most of the time it's fine. Or if the pre-invasive data actually didn't point us in the right direction, because we use that a lot to decide where the trajectories will eventually go. So if the pre-invasive data was extremely challenging, we might have some blind spots. There's not an unlimited amount of electrodes you can put in. The more electrodes you put in, the more the risk. So we have to justify every electrode, that the benefit of this electrode is more than the risk. The most, so our first patient was 14 electrodes, our second patient was 17 electrodes, and our third patient was just 12 electrodes. The maximum in the literature is around 20 to 25, but the more you put in, the more you are risking things. There are vessels, there are other structures. So you have to very carefully strategize the locations of these trajectories, so you get the best outcome of the epilepsy seizure and the spread pattern, how the epilepsy seizure is spreading. And basically, as I said, we delayed in Australia. Currently the front runners are Alfred Hospital, where I trained. They're doing a lot of SEEG. They're doing, I think, 20 a year. Westmead has been the longest in Sydney, 12 years. The first case, we did have one of the neurologists come over to help us out. And the Mater Hospital in Brisbane used to do a lot, but that's kind of reduced. So these 3 hospitals in bold are the big players. We started last year, we did 3 cases. We are quite happy with how everything went. And the data which we got was very beneficial for the patients' epilepsy counseling and what steps they might be going ahead. And there are some other hospitals which do some patchy stereo EEG. Obviously I want to acknowledge it's a whole teamwork. We have got 3 epileptologists, Dr. Lorne, who I think is giving a talk later, Dr. Dunn, we've got Dr. Chan, and we've got a big team of scientists, some of them very keen for surgical epilepsy. We've got our neuropsychologist, Mary McCann. If you guys do end up going through the surgical pathway, you'll come across her, a neuropsychiatrist. And obviously our most important man is the surgeon himself, who's really ambitious, he's driven, and he has trained a lot. And I don't know if you guys saw him last time, but he's really leading the program, and we're quite happy that we have him here in WA. And that's basically it.